Good evening, everyone. I shall be talking about how to make an informed choice with regards to high tibial osteotomy, UKRs, and total knee replacement. Thank you, Mujib, for having me here at SICOT Belgrade. My name is Vaibhav Bagaria, and I work at the Sir H.N. Reliance Foundation Hospital in Mumbai, India. As a surgeon, we all know that our outcomes are the result of choices that we make. And most of these choices are made even before we enter the theater. So, in today's talk, I shall try to convince you that the surgeon preference in this regard should be an objective decision rather than a comfort decision. I'll, I shall try to make things simple and easy at the end of this talk. So let's look at how should and how are the decisions made in this regard. So there are scientific versus non-scientific aspect. I think we are talking about the varus knee. So there are three critical things about the varus that one must know before making that decision. First is the stage of varus, what we call as degree of the varus. The second is the grade of the virus, which reflects the nature of the pathology. The third is the location of the virus, which is done by calculating cora. Most often, we rely on our wishes, whims, and fancy, and they are influenced by our own experience, our age, the age of the patient, the cost, the profession, and also the ego. There's a very tiny role for MRI when in doubt, and that is why I have put it in this slide. The key to decision making in osteoarthritis remains the radiology, which is the x rays in AP lateral scaline view and scanogram. Of course, there are secondary factors that impact our decision, which are age, occupation, the experience of surgeon with that particular procedure, and also the patient's wishes. Before I proceed, this talk is mainly science, but it is also a little bit about personal experience because I also have evolved over last 2 decades of my practice on understanding how the varus knee behaves. And a lot of it is in our paper that we publish in JBGS on how to look at varus differently. So those of you who are interested can read this paper, but primarily what it does it defines varus into two types: the stage and the grade. The stage 1 is 0 to 10 degrees of varus, which is relatively mild varus. Stage 2 is 11 to 20 degrees of varus, which is moderate, and stage 3 is a severe varus, which is more than 20 degrees. This can be easily measured with an HK angle. But what we did more importantly was to identify 10 causes, 10 features of varus which define its grade or the nature of the pathology. And we call them A, B, C. A is simply the joint space narrowing, tibial osteophyte and femoral osteophyte. Grade B is a moderate grade in which you start seeing the tibial remodeling or bone defect, the femoral bone defect, metaphyseal beaking, apart from the grade 1 features. Type C, which is the more severe type of the pathology, you can find that there is subluxation, stress fracture, or tibial and femoral remodeling. So you will see that while it is not necessary that the severe varus, which is the stage, which is more than 20 degrees, have a type C grade, but most often they do correspond. So the severe the degree of varus, the severe the grade of varus, but it is not always so. So sometimes the stage 1 varus may still have pathology which reflect grade C. With less than 10 degree of varus, you may have any of these, and that makes it a severe degree of varus in toto. I illustrate this with this example, this image, and you can see that first is a grade A, then B, and then the C. So when you look at the X-rays, our decisions for the grade B and C is very clear. These are the ones that require a TKR. So for A grade, you can choose between HTO and UKR, and possibly in a small percentage of cases TKR. In grade B and C, where there is any amount of these changes that you see on X-ray, your decision should be fairly straightforward by making it TKR. So now once that is sorted, let's talk about type A or grade A and stage 1 varus. Now here there is a dilemma whether to do a UKR or an HTO. They are a strange couple. They are different procedure, different philosophy, but most people think that they are done for similar indication, which is the medial compartmental osteoarthritis. In UKR, the procedure resurfaces the lost cartilage respective to the native alignment and the ligaments, whereas in the HTO, it is bypassing the load to a relatively unaffected lateral compartment without really addressing the medial compartment. Now, how do we decide between the UKR and TKR? I think the first step is to do a scanogram and do it in correct fashion. After you have done, you calculate the HKA, LDFA and MPTA. The first step is to look at malalignment. What is malalignment? It is the collinearity, loss of collinearity of the hip, knee and ankle in the frontal plane. So it is very important to see first of all that if there is a varus, which means that the line from the femoral head center to the ankle head center passes medial to the knee joint. Once you are sure that it's a varus deformity, you find out what is the cause of this malalignment. And this is very important because people group all malalignment in one place. So, and it is important because that's the key to correction. So you identify whether the malalignment is a femoral frontal deformity, a tibial frontal deformity, a condylar deficiency, or is it dynamic because of the ligament contracture. But remember, often it is combination of all of the four above mentioned. And in a very small percentage of case, it is also because of the extra-articular cause. So how do we do it? Primarily, if the MPTA is less than 85, tibia is the cause. If LDFA is more than 90, the femur is the cause. If there is lateral opening and JCLA is more than 2, then there is loss of cartilage or there is subluxation. Apart from that, if you look at the shape of tibia and the femoral condyle, you can know if there is a depression or malformation. And as I said, they are often combination of all the two. So you'll see that this is how there is change at the femur, tibia or can be there at both. If there is an alteration of GLCA, then it could be a cartilage wear, ligament or subluxation, which can be seen in this image. And sometime it could be because of this. We will see that either there is condylar deficiency, in which you can see there is clearly the joint line is not symmetrical. So if you look at the first image, there is clearly the medial side of tibia has collapsed, and that is why if you draw the tibial joint line, there is not a single tibial joint line. And although there are so many classification systems drawing a joint line here, the right way would be to draw a lateral joint line, a medial joint line for tibia. Similarly, on the other side, in the femur also you often get asymmetrical joint line, and it will be foolish to have a single joint line of femur and saying that this is the femoral joint line or this is the tibial joint line. In these cases, we need to have a medial femoral and lateral femoral joint line. And if it is asymmetric, this is a strong case to use an asymmetric implant when doing a TKR, which is of course a separate topic altogether, like a journey where the size of the lateral and medial femoral components are different. Now, as I said during previous talks, slides, that there is a small percentage of extra-articular deformity. There is very much of a confusion between the terminology. What is extra-articular? What is extra-ligamentous? What is tibia vara? So in this paper, we also define what it means. So joint means different things for different people. For an arthroscopic surgeon, the joint is the area between the capsule. For a deformity correction surgeon, it's a single line. But for a joint replacement surgeon and an HTO and a UKR surgeon, it should be an area, it should be a box. And it is defined by the origin and insertion of SMCL. So thus, Anything which is outside the tibial insertion of SMCL or the femoral insertion of the SMCL is or should be considered as extra ligamentous and should be dealt in a completely different manner. So let's look at which are the most suitable candidates for HTA. In my opinion, a single most important factor is an MPTA. MPTA less than 85 degrees without significant alteration in LDFA is the right indication for HTO. It seems like a narrow indication, but a great majority of our patients fall in this. Of course, there are contraindication. As I said, a mechanical lateral distal femoral angle more than 90 degree, a very large intra-articular deformity, post correction if the tibial angle is more than 95 degrees. A relative contraindication is age more than 80 degrees. Remember, this is a biological procedure, so you need the bones to heal once you have done osteotomy. So anyone who is quite elderly, quite osteoporotic, be very cautious about doing HTOs in these. A flexion uh, range less than 90 degree and a contracture more than 20 degree again simplifies a significant component of the deformity coming from the ligaments, and these should not be done for HTO. Any general complication or inflammatory arthritis is of course a contraindication for HTO. Now, any patient who is having an LDFA more than 90 degrees or MPTA less than 85 degrees or combination of both are the ones that are suitable for UKRs, or of course there are certain alternate osteotomies, double level osteotomy, intra-articular osteotomy. These are the ones which are suitable for that. So anyone who has got an LDFA more than 90 degrees or a combination of LDFA more than 90 and MPTA more than less than 85 should be the ones considered for UKR. The rest of these who have got cartilage wear, significant ligament involvement, subluxation, condylar deficiency, subluxations, malrotation should undergo either alternate osteotomies like intra-articular osteotomies or straight away go for a TKR. In brief, the surgical indications for HTOs are medial compartmental OA, sponks, posterior root tear, and the opening wedge HTO is indicated, or a hybrid CW HTO should be considered for patients who have got more complex deformities. It is also once again important to remember the presence of extra-articular deformities. So if you look at during TKR, we sacrosanctly preserve SMCL, whereas in HTO, we'll see that we are erasing a little bit of superficial medial collateral ligament, and that's the area where our work happens, just slightly proximal to the insertion of SMCL. So to conclude, the planning is the single most important factors about choosing and executing a surgery. Once you understand the cause, you plan well. So it is important to look at the X-ray long enough to know what is the cause of deformity. The first step is to calculate the degree, the stage of the deformity. Second is to understand the pathology, which is the grade of deformity. The third is to do the calculation to know where is the site of deformity. Then, based on what I have told, you choose the appropriate surgery. Do not overlook the extra-articular deformity or extra-ligamentous deformity. It's pivotal because we deal with patients. It's important to incorporate patient wishes, and of course, if you there is a certain set of skills that we own, and we must respect our skills and also our limitation. For me, an ideal candidate for an HTO is one who has got metaphyseal varus with cartilage wear on tibial side. So I'll recorrect, it is metaphyseal tibial varus with cartilage wear, and the patient should have good bone quality and healing potential. UKR, a cartilage wear with a varus which is a result of contribution from both femur and tibia in relatively older patient, and again it's a patient's wishes of what they want that should be incorporated while making a decision for UKR. TKR should be done for higher stage and higher grade of varus. Age in this case is not a big consideration given the longevity of implant that we have today, and it should be done in the rightly indicated patient irrespective of the age. I thank you all for your attention, And this slide here shows that all the varus are not the same, and that one must look deep enough to realize what we are dealing with. Thank you once again, and I welcome any questions that you may have in this regard.